Okay, so good morning, good afternoon, good day to everyone. Our topic for today is Introduction to Neuroanatomy. So the goal of this lecture is to provide an overview of the entire nervous system. As such, we will be discussing a lot of structures that are found on the nervous system, and we will not be discussing them extensively because in the coming weeks, these individual structures will be discussed exhaustively and in more detail with more depth in the coming weeks. So you only have two learning objectives today. The first is to define the boundaries of the major anatomical levels. And the second one is to be able to identify the major anatomical structures contained within each level. So this lecture is actually divided into two parts. The first part is where we are going to discuss basic anatomy in general. We'll discuss the anatomical division of the nervous system, and then we'll have basic neuroanatomy, very basic. In the second part, we shall be discussing the different anatomical levels of lesions that may involve the nervous system. We shall also be classifying the different lesions, and we'll be discussing the principle behind localization, something that you'll be applying throughout entire neuroanatomy, particularly with the clinical correlation of neuroanatomy. Okay, so let's start with a brief case. A 58-year-old man was referred to you because of recent onset of left hemiparesis, left-sided loss of proprioception, right-sided tongue deviation. So the question is, where is the lesion located? Now, it might be a little bit challenging for you now because we don't have any background yet on neuroanatomy. So in order for us to understand the problem and to localize where the lesion is, there should be a basic understanding of the different levels of the neuroanatomical structures with a corresponding presentation that are characteristic for each level of the nervous system. So in order for us to answer that question, let's have an introduction first into basic neuroanatomy. So welcome to the first part of our lecture. So there are actually two ways to divide the nervous system. So there's the anatomical basis for dividing the nervous system, and then there's the functional basis for dividing the nervous system. In neuroanatomy, we will be shifting often between the anatomical basis and the functional basis. Both of them actually complement each other in classifying the nervous system. Now, if we use the functional basis for dividing the nervous system, we can divide the nervous system generally into the central nervous system and the peripheral nervous system. Now, if we further divide the peripheral nervous system, we can divide it either as having a motor function or a sensory function. Now, in terms of motor function, it can be either a somatic nervous system or an autonomic nervous system, which could be either sympathetic or parasympathetic. Now, peripheral nervous system can also be sensory in terms of function. And when it is sensory, it can be either somatic or visceral sensory. We'll have more of these as we go through the neuroanatomy discussion in the coming weeks. Now, another means to divide the nervous system is using the anatomical basis. As always, we divide the nervous system into the central nervous system and the peripheral nervous system. So the question is, what are the structures that are considered to be part of the central nervous system, and what are the structures that are considered to be part of the peripheral nervous system? So included in the central nervous system would be the brain and the spinal cord. And anything that is not part of the structure would be considered as part of the peripheral nervous system. This would include, of course, the nerves, the connections between the network of nerves, we call them the plexuses, and the communication between nerves, we refer to them as the ganglia. Let's start first with the brain. In general, the brain can be divided into three main parts: the forebrain, the midbrain, and the hindbrain. So the forebrain includes the cerebral cortex and a mass of gray matter embedded within the white matter. This is referred to as the diencephalon. The midbrain, of course, connects the forebrain with the hindbrain, and the hindbrain includes the cerebellum, the pons, and the medulla oblongata. Now, the midbrain, together with the pons and the medulla oblongata, makes up what we call the brainstem. So the brainstem is the hindbrain and the midbrain minus the cerebellum. Let's start first with the cerebrum. Now, functionally, the cerebrum is associated with higher brain functions. This would include thought, judgment, vision, hearing, conscious control, and action. Now, the cerebrum can be divided into four major lobes. This would include the frontal lobe, the parietal lobe, occipital lobe, and the temporal lobe. So we have here the lateral view of the cerebrum. So we have here the frontal lobe. And of course, this is the parietal lobe. These two lobes are separated from each other by a very deep central sulcus of Rolando. Laterally, we would find the temporal lobe, and posteriorly, we would find the occipital lobe. Each lobe would have their corresponding associated functions, such as the frontal lobe is where we would find the center for motor control, as well as for motor speech. Touch and pressure sensation, as well as taste, is located on the parietal lobe. The hearing center is found in the temporal lobe, and finally, the visual center is found in the occipital lobe. So again, just like what I have mentioned earlier, we will discuss more of these centers as we discuss the cerebral cortex in greater detail in the coming weeks. Now, the cerebrum is actually highly vascular, and it has three major blood supplies that form what we call the circle of Willis. So these blood vessels include the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Now, what are the parts of the brain that are supplied by this particular arteries? So shaded in color are the parts of the brain that are supplied by this respective arteries. So as we can see here, most of the lateral part of the brain, particularly the lateral part of the frontal lobe, parietal lobe, and the upper regions of the temporal lobe are supplied by the middle cerebral artery. On the other hand, the anterior cerebral artery supplies the superior part of the frontal lobe and most of the medial part of the midbrain. And finally, there is the posterior cerebral artery, which supplies predominantly the occipital lobe, as well as the inferior part of the temporal lobe and the superior part of some parts of the parietal lobe. Now, this is very important because each part of the brain also has a representation in terms of the part of the body that it supplies. And this is represented by what we call the homunculus. So as we can see here, if we're going to take a look at the primary motor cortex, each part of the motor area has a corresponding visual representation of the part of the body that it supplies. So as you can see here, the lateral part, sorry, the medial part is the one responsible for controlling most of the lower extremities, whereas the superior part controls the trunk. More or less, the lateral part contains the arm and the hand, as well as the face, the tongue, and the larynx. If you notice, the visual representation of the human body is not proportional to our actual anatomy. In such case, you can see here that the tongue, the larynx, and the face, as well as the hands, are larger in terms of representation in the brain. This implies that these parts of the body have greater control, and you have a greater control or nervous control for this because they do have greater representation in the brain. Whereas the parts of your body that has less representation in the brain have less sort of control. Okay, so another part of the cerebrum is the basal nuclei. So this is actually a mass of gray matter that are embedded on the white matter of the cerebrum. So this is described as a mass of gray matter embedded on the cerebral white matter. They are referred to as the basal nuclei, which is the newer name, but in older textbooks, they are often referred to as basal ganglia. Now, currently we discourage the term ganglia because ganglia refers to communications between neurons that are located outside the CNS. So technically, the term nuclei is more appropriate. Functionally, this basal nuclei is responsible for motor control. But this is not the only function of the basal nuclei. So it modulates motor movement, but it is not only the function of the basal nuclei. Other roles includes implication in motor learning, behavior, as well as emotion. So where is that basal nuclei located? If we have here a schematic diagram of the cerebrum, embedded in the core of the white matter found within the cerebrum would be a mass of gray matter. We call it the basal ganglia or the basal nuclei. So part of the basal nuclei include, going back, the globus pallidus and the thalamus. Now let's divide first the brain into different sections so that we would have a proper orientation. So this, of course, refers to the horizontal cut of the brain, while shown in pink is the coronal section, and shown in blue is the sagittal section of the brain. So this is useful for investigating the interior parts of the brain by cutting the brain into different planes. If we take a coronal section now of the cerebrum, we would be able to view the basal nuclei that are embedded on the white matter. So the basal nuclei include the caudate, the putamen, the globus pallidus, and the claustrum. Let's enlarge this particular diagram. So let's imagine this as the cerebrum, which is divided into the gray matter, the cerebral cortex, and the white matter. So embedded on the white matter would be a mass of gray matter. We call it the basal nuclei. Some parts of the basal nuclei include the caudate, the putamen, and the globus pallidus. Now, located at the very center of the cerebrum is the diencephalon. So this is located at the innermost chamber of the cerebrum. The diencephalon is divided into 4 major parts. This would include the thalamus, sometimes referred to as the dorsal thalamus, the hypothalamus, and the epithalamus, and the subthalamus, which is sometimes referred to as the ventral thalamus. So if we divide now the brain into a coronal section, we can see here that this is the cerebrum divided into the cerebral, gray matter or the cerebral cortex, the white matter, and embedded on the white matter would be the basal nuclei. Now, at the very center, the innermost chamber of the cerebrum would be the diencephalon. Now, these two bulging structures that you're seeing, which sort of like are like kissing each other, is the thalamus. So the thalamus surrounds the third ventricle. So there are actually spaces contained within the cerebrum. There would be the two lateral ventricles, which eventually would merge into the third ventricle. Collectively, the structures that surround the third ventricle is known as the diencephalon. And one of the structures that form the diencephalon would be this, the thalamus. So let's discuss the thalamus briefly. It literally means inner chamber. So as you can see, it is indeed the inner chamber because it is located in the innermost part of the cerebrum. So this is characterized as a midline symmetrical structure located between the cortex and the midbrain. So functionally, it relays sensory and motor signals to the cerebral cortex. You can think of it as an information switchboard. So not only is it a relay station, the thalamus has other functions, such as it is involved in the regulation of consciousness, of sleep, and of alertness. Now, the thalamus can be thought of as a structure that forms the wall of the third ventricle. The floor of the third ventricle is formed by the hypothalamus. The hypothalamus is responsible for certain metabolic processes and other activities of the autonomic nervous system. Now, it synthesizes and secretes certain neurohormones. These are collectively referred to as the hypothalamic releasing hormones, which can either stimulate or inhibit the secretion of pituitary hormones. So in other words, the hypothalamus concerns the pituitary gland. Now, aside from coordinating with the endocrine part of our body through controlling the hypothalamus, by controlling the pituitary gland, the hypothalamus is also involved in controlling body temperature, hunger, thirst, fatigue, and circadian rhythm. So in other words, the hypothalamus is very much in control of the basic needs of the body that are required for the survival of the species. This can be summarized by the 4 F's. So the F's that are necessary for the survival of the species is controlled by the hypothalamus. That would include feeding, fighting and fleeing, and the 4th F is mating, or otherwise known as fornication. Now, connecting the cerebrum to the spinal cord is the brainstem. So this is located inferior to and adjoining the diencephalon. So structurally, this is continuous with the spinal cord, and it is divided into 3 parts: the medulla oblongata, the pons, and the midbrain. So the medulla oblongata can also be referred to as the myelencephalon. Pons is part of the metencephalon, and the midbrain is is also referred to as the mesencephalon. Now, there are different cranial nerves that control the face and the neck, as well as sensory nerves that innervate the face and the neck. Some of them arise from the brainstem. So for you to visualize, this is a representation of the brainstem shown in color. So it actually connects the cerebrum with the rest of the spinal cord. So it is divided into the midbrain superiorly, into the pons, as well as the medulla. And medulla is the one that is directly continuous with the spinal cord. So just to reiterate, the brainstem connects the spinal cord with the rest of the cerebrum. So it's divided again into the midbrain, the pons, and the medulla. So there are actually cranial nerves that arises from the brainstem. In total, there are 12 cranial nerves. 10 of them arise from the brainstem. This would include 3 and 4, cranial nerves number 3 and number 4 that arise on the midbrain. Number 5, number 6, number 7, and number 8 arise in the pons. And finally, number 9, 10, 11, and 12 are cranial nerves that arise in the medulla. So as we go through our neuroanatomy later on, I will teach you a secret in remembering the function as well as the location of the different cranial nerves so that it would be easy for you to remember them. This is what is referred to as the rule of 4. What is this rule of 4? Well, there are 4 things that you need to remember about the brainstem so that it would make your life easier. On the brainstem, there are 4 medial structures and they all begin with the letter M. The second rule is that of those 4 medial structures, some of them are the cranial nerves that are divisors of the number 12. 3, 4, 6, and 12. Rule number 3, there are 4 important structures located in the brainstem. They all begin with the letter S. In rule number 4, there is a very democratic distribution of the different cranial nerves on the brainstem. 4 cranial nerves arise in the medulla, 4 cranial nerves arise in the pons, and 4 cranial nerves arise in the above the pons. 2 arise in the midbrain, and 2 are located above the midbrain. So what are those 4 medial structures that are found in the brainstem that are located medially? This would include the motor pathway or the corticospinal tract, the medial lemniscus, the medial longitudinal fasciculus, as well as the motor nucleus and nerve of cranial nerves numbers 3, 4, 6, and 12. That means the nuclei of cranial nerves number 5, 7, 9, and 11 are laterally located on the brainstem. Rule number 3, there are 4 important structures that are passing through the brainstem. They all begin with the letter S, located at the side. This would include the spinocerebellar pathway, the spinothalamic pathway, the sensory nucleus of trigeminal nerve, and the sympathetic pathway. And finally, there's the distribution of the cranial nerves. Cranial nerves number 9, 10, 11, and 12 arise in the medulla. Cranial nerves number 5, number 6, and number 7, as well as number 8 arise in the pons. Cranial nerves number 3 and number 4 are located on the midbrain, whereas number 1 and number 2 are located above the midbrain and thus are not part of the brainstem. Now, don't worry about this. We'll have more of this as we discuss the anatomy of the brainstem itself, as well as the lesions that affect the brainstem. So let's put that aside for now. Now, this is actually important because this will help you locate the level of the lesion that could be located on the brainstem. Just to give you an overview, if, say, for example, there is a lesion that affects cranial nerve number 3, then we can say that the lesion is located in the midbrain. While if there's a lesion affecting cranial nerve number 12, then we can say that the level of the lesion is found at the level of the medulla. So again, I will not discuss this in full detail because you do have a separate exhaustive lecture that will be discussing the lesions of the brainstem. So do not worry about it for now. Now, why is it also important to discuss which one is medial and lateral? So aside from establishing the level, we should decide whether it's medial or lateral. If any of these structures are affected, then we can say that the lesion is medially located. Whereas if any of these structures are affected, then the lesion is laterally affected. So again, as of now, you don't have to worry about this because we shall have a very exhaustive lecture on the lesions that affect the brainstem in the coming weeks. So now let's move on to the next structure, and this is the cerebellum. The cerebellum receives information from the sensory system, the spinal cord, other parts of the brain. So the cerebellum is said to be responsible for regulating motor movement. So it is responsible for coordinating motor movement, such as posture, balance, coordination, and speech. This function of the cerebellum results to a smooth and balanced execution of motor activity. Okay, so now that we have discussed the different parts of the brain, let's briefly discuss now the going back to the cerebellum. If there is damage to the cerebellum, this can result to um, loss of coordination of movement, such as asynergia. So this is inability to coordinate motor movement. So you will also lose the inability to judge distance. This is called dysmetria. Inability to perform rapid alternating movements, such as clapping your hand. This is called a diadochokinesia. Movement tremor or intention tremor, wherein if you're resting, your posture is very stable, but when you start moving your hands, this is when the tremor begins to be apparent. So a lesion on the cerebellum can also result to what is known as an ataxic gait, a staggering, wide-faced walking. So this can be described as someone who is like sort of an alcoholic, someone who's drunk. Tendency to fall forward, weak muscles, slurred speech, and abnormal eye movements such as nystagmus. Okay, so the next structure that we shall be discussing is the spinal cord. So the spinal cord is a long structure located on the vertebral foramen, and it is divided into 31 segments, 8 cervical segments, 12 thoracic segments, 5 lumbar segments, 5 sacral, and 1 coccygeal. We shall be discussing the spinal cords in full detail again soon. So the conus medullaris is the termination for the spinal cord. So the tapering end of the spinal cord is called the conus medullaris. This terminates between L1 and L2 in the adult. This level of termination is very important in order for you to perform a safe lumbar puncture in the adult. If you take a cross section of the spinal cord, we will see that it is composed actually of a butterfly shape, gray matter, and in the center we have the central canal. The gray matter is surrounded by the white matter, which is divided into the following parts. The anterior portion is referred to as the ventral funiculus. On the lateral side, we have the lateral funiculus. And on the dorsal aspect, we can find there the dorsal funiculus. So the white matter is actually composed of both ascending and descending nerve fibers. And like what I said, this is divided. The white matter is divided into the dorsal, the lateral, and the ventral column. We have here a 3D representation of the different tracks. So shown in blue are the different ascending tracks, such as the fasciculus cuneatus and fasciculus gracilis. The others would include the posterior spinocerebellar, lateral spinothalamic, anterior spinocerebellar, and spinotectal, as well as the anterior spinothalamic. Now, what about the descending tracks? They are shown in red as the 3D representation. This would include the lateral corticospinal tract, the rubrospinal tract, anterior corticospinal tract, reticulospinal tract, vestibulospinal tract, and tectospinal tract. So for today, we are simply just going to enumerate these different tracts without regards for their function, because, like what I said again, we shall be discussing their function extensively in the coming days. So functionally, the tracts that are found on the spinal cord can be divided as the ascending tracts and the descending tracts. Ascending tracts simply mean that the tracts originate from the peripheral nervous system and ascend and terminate into the higher centers, such as either the cerebrum or the cerebral cortex. This would include the fasciculus gracilis and fasciculus cuneatus, collectively known as the dorsal right column, the posterior spinocerebellar tract, the anterior spinocerebellar tract, the lateral spinothalamic tract, and the anterior spinothalamic tract. And then there are the descending tracts, which means they originate from higher centers, such as the cerebrum, the cerebellum, or any other nuclei that are embedded on the cerebrum, and they terminate into the lower segments of the spinal cord. So to enumerate them, they include the lateral reticulospinal tract, the corticospinal tract, the rubrospinal tract, reticulospinal tract, and the vestibulospinal tract. So again, we are simply enumerating them without regards to their respective function, because as I have always mentioned previously, we shall be discussing their functions extensively in the coming weeks. So what are these ascending tracts? So these are the neural pathways by which sensory information from the peripheral nerves are transmitted to the cerebral cortex. So they are also referred to as the somatosensory pathway. So functionally, they are divided into conscious or unconscious. So they include the dorsal column, otherwise known as the medial lemniscus, and the unconscious tracts. These are called the spinocerebellar tracts. So we can divide those ascending pathway as either conscious or unconscious. The conscious pathways include the spinothalamic system, as well as the dorsal column or the medial lemniscal system. For unconscious perception, the ascending pathways include spinocerebellar, spinoolivaris, spinotectal, and spinopreticular. Now, finally, we have bundles of axons that are located outside the central nervous system. These bundles of axons that are located outside the nervous system are referred to as the nerves. So axons are actually bundles, nerves are actually bundles of axons that are arranged in fascicles. So these axons are covered by myelin sheath and covered with a connective tissue known as the endoneurium. And then they are arranged in fascicles, and those fascicles are covered with another layer of connective tissue known as the perineum. Now, when we collect all these fascicles together, what we have now is known as the peripheral nerves. The peripheral nerve itself has its own connective tissue covering. This is called the epineurium. So we have here a cross-section of a peripheral nerve. So it's covered by a connective tissue known as the epineurium, and they are composed of fascicles of axon. So if we enlarge this, we can see that the fascicles are composed of axons, and those fascicles are covered with a connective tissue known as the perineurium. And if we enlarge the individual axons, we can see here a cross-section of the axon. It has a myelin sheath covering, and then there's a connective tissue covering known as the endoneurium. So finally, we're finished with introduction into neuroanatomy. Let's now have a brief introduction to localization of a nervous system lesion. So whenever we are diagnosing a neurologic disorder, there are some basic questions that need to be answered. The first question is there a lesion involving the nervous system? Because the lesion could actually involve other systems, such as the endocrine or the muscular system. If we have already established that the lesion affects the nervous system, we now have to decide where is the lesion located. And finally, once we have established the location of the lesion within the nervous system, we have to decide what is the histopathologic nature of the lesion. To answer question number 2, we can actually divide the nervous system into 4 major anatomical levels. This would include supratentorial, infratentorial, spinal, and peripheral. So this is where you need to concentrate for this particular part of our lecture. So the question is, what are the structures that are considered to be supratentorial? The supratentorial structures are any structures that are located above the tentorium cerebelli. So the tentorium cerebelli is actually a fold of dura mater. And above the tentorium cerebelli, we would find there the cerebrum. And embedded in the cerebrum would be the basal ganglia, the thalamus, the hypothalamus, as well as cranial nerves, number 1 and number 2. So all of these structures are considered to be supratentorial. So again, there's a fold of dura mater called the tentorium cerebelli. This is the delineation between the supratentorial structure and the infratentorial structures. So what is this tentorium cerebelli? So our brain actually has a fold of, is covered with a connective tissue known as the dura mater. Then it forms several folds. One of those folds, as I have already mentioned, is the tentorium cerebelli. So this is a tent-like structure that divides the brain into a supratentorial region, if the structures are located above it, and all structures located below it are referred to as infratentorial structures. So one of the supratentorial structures would be the cerebrum. So if there's a lesion affecting the cerebrum, it can affect any of the following functions of the cerebrum. This would include the language, cognition, memory, your personality, and even your vision may be affected if the cerebrum is affected by a lesion. Now, one of the common presentation of a supratentorial lesion is that it is often affected by a blockade in the artery. So say, for example, anterior cerebral artery is blocked. This would mean that these structures would be affected. And as we know, this structure, this part of the brain controls the lower extremity. Thus, the lower extremities would be affected by the presentation. If the posterior cerebral artery is the one that is affected, this part of the cerebrum would be affected, and this would include affecting the visual function of the patient. So it is said here that a cerebral hemisphere lesion results in a contralateral body dysfunction because of the interruption of intersegmental pathway. So to make it simple, if a lesion affects a supratentorial structure, particularly the cerebral cortex is the one affected, the manifestation is contralateral to the site of the lesion. The opposite side of the body is the one that would have a presentation. This is what I'm talking about. So if the lesion is located on this side of the brain, the manifestation would be seen on the contralateral side. So that is a telltale sign of a supratentorial lesion. Why is this so? Let's briefly review the corticospinal tract. So it originates in the cerebral cortex, and its function is to control the skeletal muscle. It arises from the cerebral cortex, sends down, and upon reaching the brainstem at the level of the medulla oblongata, 90% of the fibers cross over to the contralateral side, goes down contralaterally in the spinal cord and innervates an anterior horn cell, which in turn innervates a skeletal muscle. Thus, if there's a lesion affecting the cerebral cortex, the manifestation would be contralateral. Okay, so the next lesion, the next level, anatomical level, is infratentorial. What are the structures that are considered to be infratentorial? These are the structures located below the tentorium cerebelli, but are located above the foramen magnum. This would include the cerebellum, the brainstem, and cranial nerves number 3 to number 12. So one of the guide for localization and to say that this is an infratentorial lesion is made by this statement. A lesion of the brainstem may result in segmental dysfunction at a particular level, but it may also interfere with intersegmental function below the level of the lesion. To put it simply, we can say that the lesion affects the brainstem if it affects two things. One, cranial nerves are involved, and number two, ascending and or descending pathways are also affected. So the combination of these two findings points to a brainstem lesion. Another characteristic finding in an infratentorial lesion is alternating sign. So in contrast to supratentorial, where everything is contralateral, in supratentorial lesion, it's alternating. On the side, on the structures located above the neck, the manifestation is ipsilateral, but for the manifestations below the neck, the manifestations are contralateral. So it is alternating. This is characteristic of a lesion that is affecting the brainstem. So comparing supratentorial versus infratentorial visually, for supratentorial, the manifestation is all contralateral to the site of the lesion, whereas for infratentorial, it is alternating, ipsilateral above the neck, contralateral below the neck. So cranial nerve lesion results in ipsilateral segmental function. So just like what I said, for structures located above the neck, the manifestation would be ipsilateral to the site of the lesion. Now, finally, let's move on to the next infratentorial structure, and that would be the cerebellum. So as we have said earlier, cerebellum is responsible for coordination. So if there's a lesion affecting the cerebellum, this will result in an inability to coordinate movements such as dysmetria, dysdiadochokinesia, ataxia, intention tremor, dysarthria, disturbance of equilibrium, a wide-based gait, nystagmus, and dysmetria. So we have already mentioned this different manifestation, and they all point to a lesion affecting the cerebellum. The next level of lesion is spinal. What are considered to be spinal structure? All structures that are located below the foramen magnum, as long as they are contained within the vertebral column. This would include, naturally, the spinal cord and the spinal nerves that arise from the spinal cord, as long as those spinal nerves are still within the vertebral column. So if we have here a cross-section of the vertebral column, we can see that encircled structures are considered spinal. This would include the spinal cord itself and nerves that arise from the spinal cord, as long as those nerves are still located within the vertebral column. So the spinal cord is divided into different segments, as we have already mentioned, and they do have a characteristic distribution in the body. This is called the dermatome. For example, C1 segment up to C8 actually innervates the skull cap, the neck, the shoulder, and the rest of the upper extremities. whereas most of the thoracic segment controls the trunk. On the other hand, the lumbar segment controls the pelvis and the anterior aspect of the lower extremities, whereas the sacral segment controls or innervates the buttocks as well as the posterior segment of the lower extremities. You can actually visualize it this way, and it would actually be better in understanding the dermatomal distribution of the different segments of the spinal cord. So the spinal cord lesions actually again have a very characteristic. For cervical lesions that affect the cervical segment, they affect the arm function. Lesions affecting the lumbar aspect of the spinal cord would affect leg function. And finally, lesions affecting the sacral segment of the spinal cord affects bladder, bowel, as well as sexual functions of a patient. So the level of the lesion affecting the spinal cord can actually have this manifestation as well. So if the structures located below the neck are affected, then the lesion is at the level of C4. If the level of the lesion is at the level of the C6, then structures below the shoulders are affected. A T6 injury would have a lesion manifestation affecting structures located below the ribs. And for lesions affecting L1, the lower extremity, the rest of the lower extremities would be affected. Finally, there is peripheral level of the nervous system. So what are considered to be peripheral? So these are all the structures located outside the skull and outside the vertebral column. This would include cranial nerves and spinal nerves and their peripheral branches, as long as they are located outside the skull and outside the vertebral column. So the nerve is actually, like what I said, composed of bundles of axons that are arranged in fascicles and covered with their respective connective tissue covering. So what is our guide for localization if the lesion is peripheral in terms of location? So it is said here, peripheral lesions cause an ipsilateral segmental deficit. So in other words, it would affect a certain region in the body. So the keyword is region of the body. It could be either purely sensory, it could be either purely motor, or a combination of both. If a single nerve is affected, the manifestation is local. So the findings are along a particular nerve distribution. If the lesion is said to be diffuse or polyneuropathy, it would have a glove and stocking distribution. So this is an example of a mononeuropathy. Axillary nerve is the one that is affected by a lesion, and axillary nerve innervates the deltoid muscle. So what we would find would be atrophy of the deltoid muscle. Okay, so that would be the different levels, anatomical levels of the nervous system. That would include supra, infra, spinal, and peripheral. Now, after we have localized the nervous, the level, anatomic level of the lesion, we have to characterize. So there are 5 criteria for characterizing lesion of the nervous system. That would include topography, morphology, the development of symptoms, the evolution of symptoms, and etiology. In terms of topography, this is characterizing whether the lesion is said to be focal when it is strictly confined or circumscribed to a well-defined anatomical area. Now, lesion is said to be diffuse when it is distributed over a wide range of area. It can involve either a single level or multiple level, and sometimes it can be even bilateral. Now, what about in terms of morphology? This refers to the gross and histologic appearance of the abnormal area. So it can be either a non-mass or a mass. When do we say that the lesion is of mass type? It is said to be a mass lesion when the lesion is of sufficient size and volume so that it impinges or interferes with neighboring cell function. We say that it is non-mass when it doesn't really impinge on the neighboring structure. So it does not compress, it does not destroy, or it doesn't damage nearby structures. So what about in terms of the development of symptoms? The symptoms are said to be acute when the symptoms develop within days. Symptoms are said to be subacute when it takes days for the symptoms to develop. And symptoms are said to be chronic when it takes weeks, months, or even years for the development of symptoms. So what about the evolution of symptoms? Symptoms are said to be transient. When the symptoms eventually resolve after the onset, they completely disappear. Symptoms are said to be improving when they resolve but do not completely resolve. So there's improvement, but they don't totally disappear. Symptoms are said to be progressive when the symptoms continue to increase in severity, or there could be addition of newer symptoms on top of the previous symptoms. And finally, symptoms are said to be stationary when they remain unchanged over time. Now, finally, in terms of etiology, symptoms can be either degenerative, neuroplastic, vascular, inflammatory, toxic metabolic, traumatic, or immunologic. So example of neoplastic symptoms are tumors. They are characterized to be chronic. Aside from being chronic, they are progressive, they worsen with time, and they are well defined, so they are said to be focal. Example of degenerative diseases are Alzheimer's and Parkinson's. They're chronic. It takes years for them to develop. The symptoms becomes worse with time, so they are said to be progressive. And they affect not just a particular area, but a wide area that is poorly defined, so they are said to be diffuse. So for part 3, let's take a look at some cases for localization. So a 25-year-old male fell on the ground, hitting his lower back against the gutter when his motorbike skidded on the wet road. When he tried to get up, he was unable to move his right leg. He was brought to the hospital, and upon examination, he could not feel the vibration of the tuning fork on his right foot. So let's identify the level of the lesion, and within the level that we have selected, let's take a look at what what is responsible for the lesion. So based on the history, we can say that the level of the lesion is most likely, going back, is most likely spinal. And based on that, the responsible lesion is most likely to be where he could not feel the vibration of the tuning fork on his right foot. So it's most likely to be focal on the right side. The principal pathologic lesion most likely responsible is non-mass. And the lesion responsible for this is most likely traumatic because of history. So there are also other cases that will be presented to you, but I shall not be discussing them because they are part of your laboratory activity that you need to submit soon. So at this point, we shall be ending our discussion here. So if you have any questions, just feel free to email me at dub.dubravo@feu-nrmf.ph, or you can ask me during our laboratory period. So thank you for listening.